When you say vulnerable, there are two things like vulnerability is the victim. The children are more vulnerable because of their physical competency. They might be vulnerable because of the psychological factors associated with them. And obviously the emotional harm is also there in this age group. So the persons near that could be more vulnerable because of the intrinsic and extrinsic factors. The intrinsic factors will be the physical and emotional condition of the child, and the extrinsic factors like poverty, the environmental factor associated with that, the attitude of the healthcare provider will also matter as an extrinsic vulnerability factors. So in the pediatric age group, when do you want to initiate the palliative care for these groups? So it is very well known now with all those last 1 or 2 days. I guess the palliative care is just the palliating symptoms, and you can do that through the whole life. So palliative care doesn't mean only end of life, and you can start it at any point. And it doesn't mean that the curative care options for the children do not necessarily end when you start patient on the palliative care. So it will not only the care of a child as a whole, but also his physical, psychological and spiritual care. It will not only extend to the child, but also to the broader family and the social support system, because people are in relationship. The children need more and more care with the support of the family and the friend circle and all people around him or her. There should be innovative communications. Sometimes the patients are quite critically ill and who must come from the remote areas to receive palliation. So the innovative communications like video calls, mobiles, like nowadays WhatsApp should also be done to give access of these things to the patients. And for the people with intellectual disabilities whose links with family may have been severed, the support workers may serve as their broader care unit and need to be included in this care. So what are the benefits that this palliative care gives to the children? Obviously, they will ease your child's pain and other symptoms of illness. They will provide emotional and support system to the family of the patient, and also depending on their cultural values. It will also help the child's healthcare provider to work together and communicate one another to support your goals. And it will also be a good thing to start open discussions as early as possible in his care with the child, the family and the healthcare provider for the options of care. It will also help the children and the teenager living with many serious illnesses, including genetic disorders, cancer, neurological disorder, heart and lung condition and others, who are also come under palliative care for these kids. So the relief from distressing symptoms such as pain, shortness of breath, fatigue, depression, the children might be anxious, there may be nausea, loss of appetite, problems with sleep, and side effect of medications and treatment could also be dealt with the palliative care in this vulnerable age group. It should be done to enhance your child's quality of life, and helping to cope up with the concern about school and friend might be very valuable for your child at this point. There also could be assistance with the palliative care in this group in terms of siblings in conversations. That could be providing respite care for the parents to be able to spend more time with their children, and locating community resources for services such as counseling and support group is also important. So in overall, the child, the family, the healthcare provider and the palliative care team should work together depending on the preferences, their care options and the needs of the family and the individual patient, and the whole thing should be taken together as a best modality for the palliative care in these groups. The palliative care team could be comprising of the doctors, nurses, social workers, pharmacists, chaplains, counselors, the child's life specialist, nutritionist and art and music therapist, which is also considered as a good tool to relieve these emotional outbreaks or maybe some sympathy and empathy to the patients. So the principle of the pediatric palliative care is the respect for the dignity of the patient and the families during and even after death. It will not end at the point when the patient dies. Even the after effects of the child deaths are also to a large extent. The access to the competent and compassionate palliative care is also important apart from the pain and physical symptoms. Education, grief and family counseling, peer support of the group, music therapy, child life intervention or spiritual support for both the patient and the siblings which are associated with the family, and appropriate respite care is also important. There should also be a support for the caregiver. They should not feel overburdened that they are taking care of the child. There should be shift duties or more personnel available to take care of those things. Improve professional and social support. The professional, sometimes there is not available, the palliative care facility is not available at each and every center or at each every village or society level. So social groups should be taken into consideration to provide these facilities whenever it's possible. And there should be also research and education to learn from the experience and improve for the next possible thing. So most of the time pediatric patients, cancer forms the major part of the terminal illnesses, then followed by neurological, metabolic, genetic, cardiovascular and then gastrointestinal, and there are other diseases. So when we think of pediatric palliative care, there are many issues which are involved while giving this palliative care in this vulnerable age group. There are ethical principles, there are some major challenges in the decision making. There are various participants including the child, the family, the siblings, the decision makers. There are decisions themselves which are also important to take at that time. There is a process of discussing options and reaching a consensus decision because the emotional and other factors, the family values which are attached with the children. And there is also issues like resolving conflict, and there are methods within the process which can be done to prevent this conflict of interest. The ethical principle, like most of the time, the children cannot take their own decisions, so that the substitute decision maker, which is most of the time parents are considered as a substitute decision makers, and they are required for most of the pediatric patients. Substitute decision makers and clinicians expected to act in the best interest of the patient, but many of the time the best interest is like a not universally agreed upon policy, and it can lead to majority of disagreement and conflict between the parents and the clinician at some particular time. There are also legal issues in the decision making when the children are understanding and they know their rights, not in much in our country, but in some European and American country, there are legal issues involved with those also. And the role of the significant others in the patient, child or adolescent death is also important. There in Indian families, we have the grandparents, siblings, uncle, aunts, so many people are involved in the final decision making. And there is also a nature and duration of the bereavement which is following the death of the child, which should also be looked upon when we see the palliative care in this vulnerable age group. And there is the effect of dying process and death of the child on healthcare provider. It is not so easy for the doctors, nurses or the support groups to cope up with the feeling that we had lost the child after so many things. So that thing should also be not forgotten when we deal with the healthcare provider who are dealing routinely for the care of pediatric patients. The ethical principle regarding the informed decision making should be best achieved with the help of ongoing process of disclosure. Slowly the parents, the family, the decision maker should be made aware of the conditions, the options, and they should be explained in detail what is going to happen at some particular time. Even that time frame is not yet defined or it is not clear when it will happen, still that process should start early in the care of these children. There should be family education regarding the disease, regarding the care of the patients, the emotional things which can come up, the family support, the social support, all these things should be discussed. The mutual exploration of the expectation of the family, children and the clinicians and the support group should also be taken into consideration. The perceptions, misperception from the family, society, the beliefs and values of the society where the children are staying, and the informed choices can be achieved through this process even if it occurs quickly during a rapidly progressive illness. There are many challenges in this process like demographic variation. There are so many different illnesses, like right from cancer to metabolic diseases to genetic disorders, and there is an uncertainty at the prognosis, and also there is an uncertainty regarding the likely timing of death, which cannot be ignored. There are social perspective for each and different society. There are social perspective for each and every child. Everything possible for a child can lead to consideration of any technological intervention. Obviously, it's a personal thing. Many people will say that, yes, I will do everything possible for my child. I want to do whatever is possible, whatever is the best in the world you do, even if the outcome, I don't want to care about the outcome. So that could lead to conflicts between the clinicians and the families, and simply because the treatment is available, we should not consider that it should be done in all the times, and those process of informed consent and decision making should be taken quite early into the patient's care. When and how, so early discussion about the goals of the care and palliative care options should be discussed, and aim to provide accurate and realistic information should be shared with the patient family, support care groups, and the other people who are involved in the palliative care. And without eroding the hope of the family, this should be carefully taken, like we discuss always regarding the baking brand news. So those things should also come into discussions of these challenges which we face for the vulnerable pediatric age group. Clinicians grief. Sometimes the clinician can also have problems coping with the child's death, and can be extremely stressful and grief-ridden for the clinicians who are regularly involved, or the support staff which is regularly involved in this process, including the community level workers or the palliative care workers or the nurses which are involved in this process, and can impact on the decision making when it becomes too much of a problem to handle this grief. Similarly, there are different participants. The most important are children. Some are too young or ill to participate in the decision making, and some have the capacity to make their own decision. But in between there lies a huge group who can express their wish and should be involved in the discussion, even if their parents or other will be making the decision on their behalf. But their wishes and their final wills should also be taken into consideration. Just not ignore them just because their parents are taking all the decision. Children with variable understanding of the date should be dealt correctly, and cognitive deficiencies related to the illness, like families sometimes want to protect the child and don't want to divulge any information to their children. Sometimes children know that they have some grave problem and they are going to die soon, and they also don't want to cause problems to their parents, and so they also don't say anything. So these things should be handled carefully, and the decision should be taken along with the child if they can understand the problem and the severity, and their wishes should also be taken into consideration. The family's mutual respect and trust with the family needs to be developed, and without full burden of the responsibility. Sometimes the family are poor, there are economic factors, there are logistic issue, the parents are staying away from the child, they are away from the place where they are staying, they are in the hospital. So there could be overburden on the family in terms of economic accept. There are other children in the family, so they also needs their time and to be looked upon. So that should not burden to a family that the one child is having problem and all the resources, attention is given to one child. There are other children in the family, so that should not overburden to the family for taking care of the pediatric these children. And there should be substitute decision makers, like when parents are unable, they are not able to understand completely, they are not living with the patients, and they are unwilling or not capable to act as a decision maker, then substitute decision maker should be there, and stepwise approach to appoint a substitute. Sometimes even if the parents are there, they don't want to take the decision. They say that you ask to grandparents or the uncle and auntie. So all these substitute decision makers should also taken into a quiet understanding and should be explained properly the further course of action of the child care. The healthcare team with their skills and professions is also important. The coordination between the healthcare team and the attitude which is influenced by clinical factors. If the clinician doesn't have the enough experience regarding dealing with this vulnerable age group at the palliative care, or maybe they are too busy at times with handling the other patients who are going on treatment in the hospital, there is not enough time. So these factors will also come into picture. So the clinician attitudes can be influenced by the age of the clinicians, the country of the origin of the clinicians, the length of the professional experience is also important. The seniority of the clinician will also come into play when they deal with such cases, and the number of intensive care beds, like if there is a restriction on the number of beds available in the hospital, the clinician may not be comfortable in keeping with all the terminally ill patients in the hospital and give all the care at the expense of the other patients who might benefit more compared to the patients who are in the terminal stage of their illness. So the importance of religion is also there in most of the communities where it should not be forgotten. There are many decisions which involved during this palliative care, like goals of the care, ameliorating or curing the disease, potentially life-sustaining treatments, resuscitation decisions, artificial nutrition and hydration, relieving of the symptoms, sedation. Will go and see each of them. So the goals of cure are always cure or slowing the disease progression. Sometimes the goal could be keeping the disease in the remission with the help of some, in the cancer we can say giving some chemotherapy or some tablet chemotherapy to keep the disease in the remission state. There should be also a role towards the contribution in terms of research, because this is how we improve in a future cases. The major impact should always be maximizing the normal life experience and maximizing the comfort of the patient with maximizing the period of lucidity. There should also be a maximizing the family access with care and death occurs at the preferred location. The care should also be discussed. Where do you want to make it happen? You want to keep it at home or you want to keep it at hospital only? That is also important decision in some families. Ameliorating or curing disease, first meet as a healthcare team to the patient family and identify the reasonable options of the care with the patients and their families. Then sit down and discuss these reasonable options. Openly discuss the rationale for presented options so that the latter conflict should be reduced to a large extent. Some families benefit emotionally from having everything possibly done, even if for a brief period of time. While some families accept that, yes, I understand the disease is not curable at present, the patient is going to die at some point, so they accept. But some families still want to do each and everything best possible for their children, and this mostly happens in cases of children rather than the older age groups. So there are often differences of opinion when making such decisions, and that's why the informed decision making should start very early in this process rather than when the time arises. The potentially life-sustaining treatments like withholding or withdrawing the potential life-sustaining treatment should also be important ethical and legal equivalent decisions, but may feel different on an emotional level. The parents will not be able to accept withholding or withdrawing some life-sustaining treatment for their children, and the trial of intervention on time or outcome limited basis are invaluable when definitive decisions are not possible. A decision to forego specific treatment should not lead to abandonment of all active therapy, but may lead to careful review of all the current and planned intervention. And all patients and families should be reassured that they will continue to be cared and supported even if they decide to forego the potentially life-sustaining treatment. They should be taken into consideration and should be full supported that will not stop the other treatments which make the child comfortable, even if you decide that we don't want to do the life-sustaining treatments. Resuscitation decisions like discussion regarding do not resuscitate or allow natural death orders must often be undertaken unless death is close at hand. So this may not allow sufficient time for the discussions with the family, and this in turn can lead to guilt or regret with the family that we are not able to decide at particular time and we have lost the child because of this process only. So early discussions can lead to better understanding and fewer inappropriate CPR attempts and improved family coping with these situations. Hastening death, sometimes we ask the patient to stop the relatives to stop the life-sustaining treatments, and decision to forego the life-sustaining treatments does not necessarily imply on intent or choice to hasten the death. Medications sometimes are given in the child who are too much tachypneic or who are in too much pain. That could lead to drowsiness or child may sleep, and that may be considered as some of the parent that the child is not responding, so the treatment is blamed at times that you are given higher doses and now he is sleeping all the time, he is not talking to us. So that should not be considered as a wrong treatment. So rather than using the word terminal sedation, we can use the words like we are making him more comfortable by giving him some rest, all those things. So that thing there should not be a misunderstanding, and that is reinforced by referring to the procedure as terminal sedation. So this should be avoided in some cases. Relief of severe progressive symptoms such as pain, dyspnea may require rapid escalation of the doses, and this should be adequately discussed with the relatives or the families when this time arises, and it's better to start the discussion early rather than when the time comes. Decisions like artificial nutrition, as already discussed by the previous speakers, that sometimes we always have the tendency to feed our children that they are not eating properly. So always you want this, you take this, even if they are not feeling well. So we have the instinct natural instinct to feed our dependent children, and the prospect of withholding food or water at times can evoke a strong emotion from the family and the clinicians. So artificial nutrition hydration may cause additional suffering at times by adding discomfort, or maybe you have to do enteral feeding, so you need to put up IV lines and all those things, or the enteral feeding tube. So limiting the ability of the patient to be held and comforted is also there. Side effects including the infections, obstruction, metabolic derangements, nausea, vomiting and diarrhea could occur because of the artificial feeding. Limiting food and water during the final stage of life may benefit by making the patient more comfortable. It can decrease the respiratory secretions, coughing and GI symptoms, so the patient will be more comfortable. It can also prevent the hunger sensation associated with the partial feeding at times. Decisions like relieving the symptoms relief should be a goal of care throughout the treatment of a child, regardless of the prognosis, whatever it may be. The key is consideration when making decisions about symptom relief therapies, like degree and duration of the relief which is anticipated. This is obviously with discussion with the patient at first and then the families. The potential physical and emotional distress which is associated with the therapy could be a problem if the child is getting some chemotherapy which is not going to cure him, but he is getting more of a diarrhea, nausea, vomiting and all those side effects. So he will have more problem coping up with the side effects of the treatment rather than the disease itself. The child's expressed wish is the most important thing, and that should be considered. When the treatment is not going to change the course of the disease, it is better to withhold the treatments which can cause more side effects to the patient rather than improving the quality of life. The parent preferences are also important. We should make them understand at points which treatment is going to make him better and which treatment is going to cause more hazard than the betterment of the patients. The child proximity to death is an important thing, and relieving symptom at time becomes difficult. So these things are a little bit difficult to explain, and emotionally these are difficult to accept to the parents. Alternate approaches like availability and efficacy of other treatment should be considered. Financial implications are the most important thing, and that is a major factor in our country. I feel that most of the time the parents want to do something, but because of the financial things we are not able to do each and everything which is possible for the better quality of life in these cases. The sedation at the end of life, sometimes near the end of life, function cannot be maintained without compromising the patient comfort. When this occurs, medication including sedatives, analgesics should be titrated to adequately reduce the symptoms of the child, even if this means that cognitive, respiratory or cardiac functions becomes compromised as a result. This approach can be easily misunderstood as an active hastening of the death, like I discussed earlier. That sometimes the relative might think that child is not responding now, so that has happened because you had given the high dose of some medication which is sedating the patients. So clearly communicate to the family that these medications are given to relieve the symptoms, and they may cause secondary or unintended effect of shortening the life by few hours or days. Planning for the last days and hours. So full understanding of the patient's medical situation and all the possible events and decisions point that may arise should be taken. Careful consideration of the family's patient's wishes, best interests, beliefs and goals as well as those of the family should be considered. Recognition of the prognostic uncertainty and inevitability should be explained. Unanticipated situations and decisions should be properly discussed. Although not frequently used in pediatric palliative care, advanced directive or living wills can be considered as a useful tool in these cases. The best method for preparing unexpected is for the designated decision maker to have frank discussions with the families. There is a process to do that, so evaluating options, parental involvement in the decision makings, obligations to the clinician, to the decision makers, maintaining the continuity of the discussion or the staff which is involved is also important. Sometimes the shift duty is there, sometimes the new person comes, so that should be avoided as much as possible. Practical suggestions for the patient and family should be given, and preventing conflict and disagreement is not synonymous with conflict should be understood. There should be more communication with the family and consensus building with the help of willingness to be involved, well informed about the potential benefits, burden and risk of the available options should be explained, and emotional and mental capable of the participating individuals, families should be also taken into consideration. There should be also effort made to resolve the conflict wherever possible by making the expressing interest to resolving the conflict, allow emotional expression, respond empathically, seek an agreement to focus on the decision at hand rather than the emotions. Second opinion and case transfer can be done when there is a conflict which cannot be resolved. And of course, it should be done with the training and supporting clinicians. Role plays should be done, reflective practices through writing exercise, group discussions, CMEs or conferences which are doing, training involved in and trainee involvement in the multidisciplinary team and debriefing should also be done. And there should be provided list of resources like books, reputation on line info, etc. should be done. And I always feel that there is always something that can be done, even if it is simply to sit beside the patients and hold her hand and offer a few words of comfort and solidarity. Thank you very much. Thank you.